I'll just give a brief introduction to Tana. Tana is Tana Longneck. She'll be the moderator for our next session, Truth and Reconciliation, or Journey to Equitable, Accessible Healthcare in Saskatchewan. She is the Executive Director of First Nations and Métis Health for the Saskatchewan Health Authority. Tana is Saulteaux and from the Fishing Lake First Nation in Saskatchewan. She has spent most of her career devoted to improving the quality of life for others. Welcome and thank you, Tana.
Thank you for the introduction, Elaine. I'm coming to you today from Treaty 6 territory and homeland of the Métis. I'd just like a friendly reminder to hold questions in the, for Chief Delrome, and those will until after his presentation. Our keynote speaker is Chief Cadmus Delrome. Thank you for sharing your time with us today, Chief. Brief introduction, Chief Delrome is Cree and Saulteaux, and he is the chief of the Cowes First Nation. Chief Delrome pursued a Bachelor of Business Administration and a Master's of Public Administration, and recently he has completed a Corporate Director's designation. Chief Delrome was named one of CBC's Saskatchewan's Future 40, which celebrates the province's new generation of leaders, builders, change makers under the age of 40. This past year, Chief Delrome faced one of the hardest moments as a chief when the Saulteaux and Cree First Nation made international headlines with the discovery of potentially 751 unmarked graves near the former Maryville Indian Residential School. Shortly after, Cowes made headlines again as the first First Nation community to sign an agreement with Ottawa and return jurisdiction over children in care to the community. Federal legislation overhauling Indigenous child welfare was passed in 2019 and came into force this year. Chief Delrome lives with his wife, Kimberly, his brother-in-law, daughter, and 2 sons on the Cowes First Nation. Welcome, Chief Delrome, and over to you.
Nanaskamun, thank you very much. Kimi Gwich to Knowledge Keeper Judy for the beautiful opening prayer. Cadmus Natisi Kasu, Cowes Uchinia, I come to you from Cowes First Nation. I'm 39 years old. I'm an elected chief. I look young. That's that reserve water. I get to shower in every day. That makes me look so young. I'm really excited for the next 15 minutes. I got to put my timer on my watch because I tend to make my stories really long. And in the next 15 minutes, I'm going to what we call tension and release. I'm going to talk about some pretty tense things and then probably have a laugh or two. One of the things in Indigenous ideology that many of you in the health environment have seen is Indigenous humor, in how we laugh. And once it's contagious, we don't know how to stop laughing. But humor is a part of our laws as Indigenous peoples. And that's something that has been a missed opportunity that this great country has not taught proud Canadians. And so in order to move to reconciliation, we must first understand and accept the truth. And so I'm going to try to deliver everything I can in the next little bit for what I just spoke of. But before I get into that, I just wanted to say this pandemic has been pretty tough on many, and all of you that are serving this great province and country in the health field, I say in the Naskamun, thank you very much. It's tiring. I could see as a chief, it's tiring from my area and what we do as leadership, but we're all in this together and we're going to get through it. So thank you very much from behalf of all my citizens and my family and myself. One of the things about humor is it comes in many ways. But if you're sitting amongst Indigenous people and they tease you or they, include you in their laugh, that's actually a blessing. It's a blessing because humor is about kinship. It's about cohesion. It's about welcoming. when normally when you get teased, that means somebody likes you. And, so I just mentioned that because sometimes if you walk into a waiting room or you see someone and, normally it's not a great situation why they're in the hospitals or in the health system, but, humor is keeps sane, it keeps grounded. One of the things I've learned in the last 6 months being a chief with the Kamloops, the Maryville, and the many other residential schools telling their stories, I've seen two approaches. For Indigenous people, it's validation. It's validation of the pain, the hurt, the frustration, the tiredness of fighting to remain Indigenous. And for my proud Canadian relatives and friends, it's validation that that shield is down now. And we're starting to admit that we don't know much between the truth between Indigenous people and this country. And that is something that we all inherited. If I'm trying to say something over and over, is yes, we did inherit this. Absolutely, we did. We didn't create residential schools today. We didn't create the Indian Act. We inherited it. But the thing is if we don't do something about it today and address it directly and have those uncomfortable conversations, ultimately what we're doing is we're telling our children and grandchildren, you figure it out one day. And I'm for one to not do that. I got a 5-year-old daughter that I want her to be a dreamer. So we got some very tough conversations to have. One of the things in our health field and our education field is how when we learned in our time and prior time, there was a huge missed opportunity on speaking the truth. And what do I mean by that? I'm going to break it down into generations. The baby boomer generation, our elders, our Katayak in the Cree language, our knowledge keepers. One of the things in Indigenous ideology is if you live to see 3 generations, you have earned your stripes to be in the knowledge keeper category. Sometimes we put age numbers to it, 55, 60, 65, but in tradition, it was 3 generations. And so our baby boomer generation today, we lean on them. We lean on them for knowledge, for comfort, for guidance. But one of the things in this country is sometimes the ignorance or accidental racism that comes with Indigenous people in how the education system told the truth. The baby boomer generation, the only education they truly got about Indigenous true history is through Hollywood movies. The way that John Wayne would normally beat the Indians or cowboys and Indians, my ideology is pretty much painted as teepees, riding on horses in breechcloth and giving out war calls. And that education system was not set up at that time. So the next generation is the Generation X, the Generation X that came after the baby boomers. The main education system at that time was the white paper. The 1969 white paper of why don't we just abolish reserves? Why don't we just give up status to Indians? Why don't you just be Canadian? Why do you want to stay being Indian? That is not the solution. But unfortunately, Generation X, the white paper was an option. Generation Y started to get it a little better. Generation Y, you started to talk about treaties, but more about land surrender. You start to talk a little bit about residential schools, but they were actually still going on until 1996. And so our millennial generation and our generation today, our Z, they get it. They're getting taught the spirit and intent of treaties. They're being taught about the truth. But unfortunately, in this country, there isn't an Indigenous Studies 100 course that's going to be mandatory across this country. It is up to each and every one of us as proud Canadians to take it upon ourselves to teach our individual selves, our kinship, our social lives, our organizations. Right now, what we're doing is we're exercising number 57 of the Truth and Reconciliation Calls to Action. That's professional development. So give yourselves a little bit of pat on the back that the TRC is being implemented, because that's what this is it's professional development. And so moving forward, we got a lot of work to do. I have a couple of slides here I wanted to show you And please, if you don't see it, let me know, but I'm pretty sure you can. I'm getting pretty good with Zoom. But this is a picture of ancestors on the plains where we live today. And so I'm not sure if this is Regina or Cowses in the background, but it's really beautiful. So I'm going to say it's Cowses. And these are ancestors to Indigenous peoples. There's a story in a research report of in 1850, 3 surveyors came from Ottawa to the plains because they knew that this land was about to be conquered. It was about the Europeans, the Canadians, the pre-Canada, the British was about to come west because they still weren't in the west. They were still only as far as Winnipeg at the time, and they were interacting with the Métis. And so 3 surveyors came, and they came across these 3 warriors on horseback. And this is in one of the written ones that came over. And these 3 came on horseback and they rode up. And in the book, he talked about them as so intimidating, so confident, so stoic, and at the same time, so hospitality ready. They didn't speak one word to each other because they couldn't understand each other. But these 3 warriors on horseback gave them 2 days of hospitality, fed them, guided them with just using their hands, and they sat around the fire, and this surveyor wrote in his book at how funny they were. Like they just talked to each other and laughed at each other, but yet when they talked to the surveyors, they're so stoic again and trying to be tough. And so they even packed them up some to go on when they left back to the east. These are ancestors of Indigenous people that are 6 generations removed. In his book, in this report, he said they were amongst the most healthiest people they've ever seen in their life. And so today in 2021, after 5 generations, what did the Indian Act do to Indigenous people? It imprisoned the minds of Indigenous people. It put women at a lesser leadership role. It stopped Indigenous people from being a good governance to an Indian Act hierarchy. We bow to the crown kind of attitude, and that it's not the right approach, and it still is happening today. What did residential schools do to Indigenous people? It tried to brainwash us. It tried to brainwash us from kinship. It tried to brainwash us from our language, from why men have braids in the spiritual connection. And because of that, what do we have today? What's the real loss of control that we see in health today? Well, the loss of control is as follows. In the red words, loss of language. That is really key to identity. And it's starting to come back. We have a language program on Cowses right now. This is how bad Cowses was colonized when it come to language loss. We have 4,300 citizens. Less than 10 spoke fluent language 2 years ago. Because of a grant we got from Canada, now we have about 50 that speak the language. So it's coming back, but it's not an easy task. Political control, chief and councils. We as a chief, I run for chief, they said. It would be fun, they said. I use that comically, but I absolutely love my role. But being a leader, you manage poverty. You manage mental, physical, emotional poverty, and it's daily. And so you need very thick skin and try lead by your heart. It is challenging at times, but it's getting better. Governance is needed. Governance training is needed. Social control, spiritual control, that also includes religion. But we need to have faith. And so spiritual control, religious control is required. Health is one of our biggest challenges right now. Diabetes, mental health, suicides in the north. Like that is huge, and it needs an overhaul. One of my main statements here is we got to stop making people in Indigenous people's custom. We got to stop making Indigenous people change to the system. We got to really focus on changing the system to address Indigenous peoples. And that is tough because the health system is a big machine and it's really tough. Economic control. Every child should wake up and watch their children every child should wake up and watch their parents get ready for work during the week. It's not just because people have 2 hands and 2 arms, they can just go to work in the morning. We got mental, emotional challenges, situations we got to invest in. Please, I'm not painting the picture that all Indigenous people are in some kind of poverty. There are many amazing stories, but I'm just getting right to the point of the core of what we inherited. Cultural control. We have to make sure that we gain control there. And the lines on the outside is what we see today, what we see at the surface: family violence, dependency, low self-esteem, blame, shame, anger, denial, withdrawal, depression, addiction. It's there. I'm going to skip this one because I want to make sure I get to my main points. This is what I mean by we inherited this. I use this picture because I'm not a cowboy. I was put on my first ever horse, and somebody captured a picture with me in my headdress, but I'm what you call a drugstore cowboy. I do own cowboy boots, but they've never thrown a bale in the back of the truck in my life. So that's I'm trying to live my late dad's cowboy boots walking. But one of the things in this picture is a quote that I kept saying this summer, is we inherited this today. We didn't create it. But what is it that we're actually really looking for? What is it where did it go wrong? Where can we do better? We got to stop thinking of Indigenous peoples as trying to just form to the system. My signatory chief, I got 2 last stories here. My signatory chief, he envisioned treaty. And we got to start with treaty, because treaty is going to really help build our relationship stronger. He thought of treaty as 2 canoes going down the river. One canoe, the Crown, Canada, Saskatchewan, the other 2 canoe, Cowses. And then if you're another rights holder, think of that in this canoe. We were supposed to flow down the river as long as the sun shines, grass grows, river flows. Every generation, we were to give each other a child so they'd be raised in that other canoe, to know that ideology of that canoe, and then give them back. Every generation, we would always adapt to the changes. That didn't happen. What happened was the Indian Act got thrown in the Cowses canoe, and it tried to imprison our minds. It slowed us down. Then the residential school got thrown in our canoe. It tried to brainwash our minds. It slowed us down even more. Now today in 2021, Cowses, we're not asking Canada to slow down. We just want to catch up to where we should be. We want to catch up, so we need investment in our canoe. We don't want to go a different river. We don't want Canada to exit. We love where we are today. The thing is we're just tired of everybody trying to oppress. And the system it's so big that it's going to take a lot of hard work and big decisions to change it. That's my last thing. It's my mom and my boy turned 1 today. And for the health people, yeah, that's a Pepsi in the back. And yeah, my mom gives my kids Pepsi, and I don't agree with it, but that's something I can't stop, as my mom is a kokum, a grandma. What is intergenerational trauma? I'm going to leave you with this. What is intergenerational trauma? This is what intergenerational trauma is. Our Charter of Rights and Freedom in this country guarantees vertical lineage, meaning that grandma can teach mom, mom could teach daughter, daughter can teach granddaughter. That same charter did not protect Indigenous people for 3 to 4 generations. And this is what happened. My mom's grandma, her name was Mary. Mary never attended a residential school. My mom's great grandma, Mary. My mom's grandma, Maggie, attended the Round Lake Industrial Residential School. Maggie should have got vertical lineage from Mary, her mom, but she didn't. She went into horizontal survival mode. Maggie was surviving with her sisters and siblings and cousins from the physical, sexual, mental abuse. Maggie had my grandma, Evelyn, 2nd generation, horizontal survival mode. Same thing. Evelyn should have got Mary and Maggie's teachings, but she was unable to. Evelyn had my mom, Charlotte, 3rd generation in my bloodline to go to residential school. My mom went into horizontal survival mode. Again, the same situation. Then my mom had me. I didn't attend a residential school. My mom did her best to raise me what she thought a parent should do. And she had challenges. My mom has intergenerational trauma. Now today in this picture, my mom gets to do it again with my kids. And so it's coming back. But every Indigenous family in this country is different. Some have vertical lineage. They've overcome, they've persevered. I just love it. Some are at a 45-degree angle. Some are still horizontal survival mode. We must not judge. We must invest, because if we don't, we're pretty much telling our children, you figure it out. And I don't want us to do that. I thank you very much for letting me share a few words, and hopefully there's some questions or comments. And again, thank you all for what you do to help keep us safe. And Anaskamun, thank you very much.
Thank you, Chief Delorme. I'm just going to actually look over into the chat, and I don't see any questions at this time. But given the essence of time, I would just like to maybe go into the other panelists and introduce them, and then we'll have a Q&A shortly after each of their 10-minute presentation. So moving on to Dr. Rachel Asiniwasis is a board-certified dermatologist currently practicing in her original hometown of Regina. Since graduating dermatology residency at the University of Toronto in 2014, she currently operates her own practice within Regina, seeing a wide base of patients in southern Saskatchewan. Since 2015, she and her small team have expanded to service several remote and northern First Nation communities around Saskatchewan in a grassroots initiative. Dr. Malcolm King is a member of the Mississaugas of the Credit First Nation and a health researcher at the University of Saskatchewan. From 2009 to 2016, he led the CIHR Institute of Aboriginal Peoples Health as its scientific director, spearheading the development of a national health research agenda aimed to improving wellness and achieving health equity for First Nations, Métis, and Inuit in Canada. Malcolm is the scientific director of the Saskatchewan Centre for Patient-Oriented Research. He continues to teach research in Indigenous health with a particular focus on wellness and engagement. Patient partner Maggie King. Maggie King is a wolf clan of the Mohawks at Akwesasne and a band member of the Thunderchild First Nation. She is residing in La Ronge. Maggie works for the Lac La Ronge Indian Band Health Services as a health promotion worker. She also sits as a patient partner for the Saskatchewan Centre for Patient-Oriented Research on the Patient Partner Advisory Council and the affiliate Indigenous Health Advisory Council. I would like to move on to the presentations. Dr. Rachel.
Thank you. So I'll just share my screen now with my PowerPoint. Perfect. So thank you for having me today. I'm Rachel. I'm originally from Regina, and some of you may know my dad. He's Blair Stonechild from Muscopeting Reserve. And my parents just live 5 minutes that way, so I do see them quite frequently. So I do run my own private practice, which is independent in Regina, called Origins Dermatology Center. And I'm just going to move on for the sake of time. I'm going to be speaking about a few different things today. My disclosures include I have been a medical consultant for atopic dermatitis and psoriasis. So what I'm going to be reviewing today is dermatology in remote Canadian communities in a Saskatchewan context, the digital divide, and an overview of current research projects. So before I get started, I just wanted to let you know that what we know from published literature, so limited published existing literature, experiences of healthcare providers, and media, which I'm also going to cover, they are all pointing to the same concerns around atopic dermatitis, which you may have heard of as eczema, and skin and soft tissue infections. This is further compounded due to a primary dysfunctional skin barrier, things such as deficient antimicrobial proteins and an immune system dysfunction. These patients are at increased elevated baseline risk for skin infections such as MRSA or other bacterial infections. So this is what we're starting to see a crisis arise, and it's very poorly documented. The other thing I'm going to mention is if any of you are thinking, oh, it's just a skin problem, and I've heard this enough from my patients being dismissed from their gym class to their primary healthcare practitioner's appointment. I don't know if you've ever known anybody who has had moderate to severe eczema, or if you haven't had a skin problem, if ever in your life you'd had itching and it like a mosquito bite or something. Imagine having that all over your body and it's not going away, it's not being treated. So peer-reviewed literature suggests that chronic itch and chronic pain can impact people in the same way. So the other thing I wanted to mention, it's also very well documented with atopic dermatitis or eczema, that if you actually look at the whole person, for example, in the lens of the medicine wheel and balance, we're seeing that there is well documented impacts of things like insomnia, bullying, anxiety, even an increased risk of suicide. And the other thing that I will mention is, according to Nature Journal, atopic dermatitis is the most common chronic inflammatory skin disease. So common conditions going unaddressed in these areas, and that is what I'm presenting to you today. In my opinion, the burden is beyond severe in these communities after seeing several thousands, perhaps more than that, patients to date. If you actually look into the limited published literature, you will see that the actual prevalence of atopic dermatitis is unknown. It may be up to 16.5% according to some prevalence studies from the East Coast, but more information is needed. There was an article reported in the BMJ in 2020 by no Indigenous authors that demonstrated that there was a high and concerning level of systemic antibiotic prescriptions, in which about 40% of them were for skin and soft tissue infections, a high burden being MRSA. They concluded that these populations are hard to reach and underrepresented in the standard surveillance system. The other thing that I would like to point out is, according to the First Nations Regional Health Survey, and I have literature both out of Ontario and BC, we're seeing the atopic triad, which is eczema or atopic dermatitis, asthma, and allergies. That's the top condition we're seeing in First Nations youth in Canada, are these three things, top three chronic conditions. And I also want to let you know that literature shows that atopic dermatitis or eczema is the first step in the atopic march, or the atopic triad, to develop those further diseases. And that the hypothesis is that sensitization through that skin barrier can lead to other problems, including asthma and allergies. So if we can stop eczema or atopic dermatitis, perhaps we can help decrease this burden on youth in general. So if you are concerned about youth, you will look at the most common conditions that they are reporting from a chronic standpoint. This was a survey that we did, very basic survey from our students and residents. And thank you to Mamata Pandi, she's awesome. I think she's here today. But we had a lot of nurse practitioners and nurses actually working in the Indigenous communities, and a lot of them were identified as Indigenous. And they again identified that here in Saskatchewan, eczema or atopic dermatitis, I've used those synonymously, and impetigo, which is a bacterial infection. Remember, these kids are not just kids, but people who have atopic dermatitis are prone to that, are the top two again. So we're seeing themes, okay? Look into the media now. There are reserves calling out for help publicly in the media, okay? All of these are publicly available photos. They are not my own patients. And if I was to show you the referrals I get, I can tell you that you would be shocked to see a 6-year-old have over 40 courses of antibiotics. Okay, so like I said, what I'm seeing, unfortunately, is no different in Saskatchewan, and there's a crisis in pediatric communities that is not being documented. Okay, so that's my research interest. Hopefully that we can connect with them by building a bridge and building a connection. We have to work together to help the youth. But again, I see crusted impetigo. There might be a component of eczema herpeticum, very, very severe chronic crusted atopic dermatitis. And you know, some children were getting flown out of Saskatchewan Reserve in Ontario. And again, we're seeing these reports out of different reserves in Ontario. But I'm telling you now that in Saskatchewan, there is a crisis as well. What I do is I hold my in-person clinic. My center is based in Regina, where I see the general population, and then I do have remote outreach to all of these communities. Next week, I'm going up to Isle La Crosse, Métis community for 3 days, and then I go up to La Loche, and I see patients, and we complement with virtual care. Combination of drive-in and fly-up. I take samples up. Here are some of the planes in the hospitals. I take all of my own equipment. Okay. Sometimes you'd be surprised how hard it is even to find a pair of gloves or a polysporin. So I bring everything in what I call the remote tote, and we take samples. And there are barriers reported that need to be further demonstrated. I'm running out of time, but just really quickly, I just wanted to mention that if you again look back to the First Nations Regional Health Survey of Ontario, you look here, the top reason why children and youth were getting treated was for eczema/atopic dermatitis. So that tells you, despite all of these barriers listed here, they are getting treated. So there's an impact. It's not just a skin problem. Other barriers reported, and this is something I'm seeing directly by being in the communities. I'm not a water expert, but if people are afraid of their water, they're not going to use it. Fundamentals for bathing and moisturizing, skin care for atopic dermatitis is not happening. It's often due to expense. Just like food prices can be inflated, so can products for fundamental skin care, hypoallergenic skin care, laundry detergent, okay, moisturizer, body wash, bleach, and so forth. Okay, so we're seeing inflated costs. And if the communities are in poverty, even as a dermatologist, seeing that $37 of non-hypoallergenic laundry detergent, I don't think I would even buy that. And then you throw on crowded housing on top of that. And we're seeing things like scabies, lice, and impetigo. These are communicable diseases that can be cured. And we need to have some kind of guideline or procedure in place to treat these people, because it's really hard for me to do this by myself. And I receive no nursing support from SHA on site. This is all me and my administrator dealing with this. We had an Indigenous Skin Summit in March featuring many Indigenous leaders and speakers. And my father opened it, Blair Stonechild, with an overview of Indigenous history. And one of the potential solutions that we proposed was optimize virtual care. And it sounds exciting, but, and like I said, I'm hurrying now because I'm running out of time. Are we putting the cart before the horse? Okay. If you actually look into Canada's high-speed internet connectivity report, the iron triangle of healthcare says from a cost, quality, access standpoint, you could never have all three. You're going to compromise one. But if used appropriately, virtual care could actually improve all three. However, and if you see here, like I've signed off on patients who travel, let's say from Pelican Narrows to see me, I signed off on their NHB stipends. It can cost over $2,000 sometimes if you count the reserve driver, the gas, the time, the meals, the accommodation, right? They might have to take a caregiver to child. So how can we reduce these costs? Teledermatology and virtual care might be good, but the only problem with this is, according to the most recent survey of high-speed access for all, about 97% of urban homes can have the appropriate bandwidth to do this. And I have spoken to one of my colleagues who's a leader who also agreed that it's a problem in teledermatology out in Toronto. And only about 24% of households in Indigenous communities have this access, and 37% of rural households. So like I said, we're putting the cart before the horse if we're putting all this emphasis on virtual care. And this is only a national report. I don't know about the Saskatchewan context. And like I said, I'm just learning about this. We do have some research projects right now undergoing. This includes, we are recently published in pediatric dermatology, so I'm actually presenting my research nationally now. I'm happy that Saskatchewan has finally invited me to present this. I'm also working on a systematic scoping review of atopic and dermatologic disease. I'm working alongside some researchers here on a project, again, which I'm running out of time. We're going to be presenting our national survey shortly across Canada. And we're also trying to involve the communities in sharing feedback on their experience with skin conditions, to involve the communities. And then the other thing is, anyways, we're working on trying to get this something documented, because at the end of the day, I found that I can meet with people and I can do this all day long, but unless it's documented, I find that I don't know if any action is going to be taken. So I really do think that we have to work with the communities to develop a connection, long-term connection, kind of like what Wellness Wheel has been doing, because, documentation alongside Indigenous research methodologies are needed in order to document this in a culturally sensitive way, in order to inform policy and decision makers that there are issues that need to be addressed. Here are my references, and thank you for having me.
Thank you, Dr. Asiniwasis. I will turn it over to Dr. Malcolm King.
Thank you very much for that introduction, and to the previous speakers and the Elder Judy to begin. So Chief Delorme has made my presentation much easier and shorter because he covered the historical trauma that everyone actually has referred to, but he did it much better than I can as a professor. Next slide, please. I'd just like to acknowledge the territory, Treaty 6, and the homeland of the Métis. Next slide, please. So Chief Delorme talked about the treaties and how they should have respected the First Nations and the settlers in equity, but this was not the case, as we all know. The numbered treaties that occurred after Confederation were treaties between unequals. Our peoples were relegated to small plots of land that was not sustainable, and it was furthermore, if you go to the next slide, massively interfered with through the Indian Act. And again, Chief Delorme talked about this, so I won't go through it, but on to the next slide. He talked also about the residential schools. I was fortunate enough, and my father, not to have residential school experience, but this certainly happened to large numbers, more than 150,000 children in Canada. Next slide. And then finally, as the residential schools were starting to diminish in a way in the 1960s, they did go on for more than 30 years, though. First Nations Children in Care, the foster system, in a way took over and continued that multi-generational trauma. Next slide. And so what I will get to again is to talk about the Truth and Reconciliation Commission. This came out of the federal government's apology for the residential schools that was presented in the House of Commons by then Prime Minister Harper in 2008. And they presented their report in December 2015 to newly elected Prime Minister Trudeau with 94 calls to action. 7 of these concerned health. And if you go to the next slide, I would like to talk about 3 that I consider really important. In fact, all 7 are important, but this was our national commission, which collected evidence, and also, of course, they built on evidence from the previous commission, the Royal Commission of 1996, that acknowledges that the current state of Aboriginal health in Canada is a direct result of previous government policies, including residential schools. In fact, it's that whole history, the Indian Act, foster care, the criminal justice system, and so on. And just like Chief Delorme said, and the TRC says it very clearly, we need to set measurable targets. We need to do something about it. And it has to be done in collaboration with First Nations, Métis, and Inuit to achieve the results. And to me, this is an ethical obligation. Another important call to action from TRC is number 22, which recognizes the value of Aboriginal healing practices and calls on the use of these in the treatment of Indigenous patients in collaboration. Next slide. There are 2 other ones, number 23 and 24. Number 23 talks about increasing the number of Indigenous professionals in healthcare and ensuring their retention, but also providing cultural competency training, safety training for all healthcare professionals. And this really extends to research, and this is what SCPOR, the Saskatchewan Centre, does, providing this kind of training for all of our researchers and trainees. And then finally, number 24, again, you need to have a whole day. You need to have more than a day of this. You can't do it in just an hour, hour and a half lesson, but everyone does need to take a course, to take training in Indigenous health issues. That includes the history and legacy of residential schools, the treaties, the United Nations Declaration, and all of these. If you go on now to the next slide. So I want to deal with some important principles that we use to apply, not just in healthcare, because they're important there, but also in research that we do. And this first one was developed right here in Saskatchewan by Willie Ermine, who is not only a professor, a philosopher, Sturgeon Lake Cree Nation, but now as a retired professor, and in fact, he's been for a long time. He's a lodge keeper and an elder. He talked about two groups, the Western group and Indigenous groups, meeting each other, getting together, and finding that common ground, that understanding, and the mutual respect between the groups. And Willie Ermine termed that ethical space. And that's an important thing in research, because when Western researchers engage with Indigenous communities, Indigenous people, they need to work to find that common understanding before they can really proceed. The next slide. So this is another fundamental principle that we apply. It looks a bit the same as ethical space, but it's really different. It is referred to as two-eyed seeing, or Aptumunk in Mi'kmaq, from the elder Albert Marshall, who first put it forward, to see from one eye with the strengths of Indigenous ways of knowing, and to see from the other eye with the strengths of Western ways of knowing, and to use both of those eyes together. This is the synergy, and it's a synergy that was right there in Treaty 6 in the middle of Saskatchewan and Alberta, what's now those provinces, from 1876, where the treaty is known as a medicine chest treaty, as many people know. But the idea was that it wasn't replacing the Indigenous medicines with Western medicines, but adding them to, and to continue with both Indigenous ways of knowing about healing and medicine, and adding to them the strengths of Western developed ways of healing and Western medicines. Next slide, please. So I will finish this abbreviated presentation by just talking about, as I see them, the ways forward in health through decolonization, to recognize that historical and ongoing trauma is an underlying contributing factor to the current state of health of Indigenous peoples in Canada. Actually, you can put any disease in there. I happened to present this to a group of respiratory physicians recently. Working collaboratively to address the gaps by setting targets and monitoring the results of intervention programs and policy changes. To incorporate Indigenous ways of knowing and doing in healing practices. And Finally, engaged research needs to benefit Indigenous communities. Communities need to be partners in the research, and research needs to improve the quality of patient outcomes. And that's what makes it valid and ethical. This is what we're trying to do at SCPOR in our work in partnership with Indigenous communities. So with that, I say Chimagwech. Thank you very much.
Thank you so much, Dr. King. Maggie, please go ahead with your presentation.
Hey, thank you. I'd like to thank the organizers for inviting me to speak, and I'd also like to thank Judy for her prayers and support throughout the work of SCPOR, and also Gilbert too. They start off our meetings in a good way, and I'd like to express my gratitude for their work that they do in the community. As individuals, we learn differently, and we learn by seeing and doing. We witness both good and bad in our world. Imagine a world where you are torn away from your family and not seeing or hearing from them for great lengths of time. Imagine when you spoke your mother tongue, you were immediately struck so hard your ears rang and you were given no explanation for your apparent transgression. Or worse, you died from the blow. Think of all that is familiar to you as a child is now a blank slate. What child can make sense of this kind of world? What pain and suffering is carried forward in their subconscious? Imagine returning home, not being able to understand your family as they speak their original language, or being able to navigate safe and unsafe environments for lack of being and living on the land. Imagine never returning home and family never given information or reason for the loss of their child. Some people overcame these barriers in different ways, learning as best they could how to navigate in a hostile environment, learning a foreign language and foreign ways of being, and having a foothold in two worlds. Others determined to strengthen their own culture and language and return to the place they felt safest, welcomed, and wanted. They found purpose in choosing culture and language for a lost generation. Now imagine there's only a handful of people in your world that can speak and understand their native language and teachings and live a life close to the earth. What does the future hold for you? There are a myriad of ways these losses have embedded themselves in the psyche of a people. Through the lived experience of trauma and its after effects, we are learning new ways of dealing with unresolved trauma, how it imprints on the brain, its development in children, and trauma that has been passed down through generations, negatively impacting our health with chronic diseases. This is what happened to us on an individual level, as well as a collective. Colonial policies imposed their agenda on Indigenous peoples by force. Maurice Merleau-Ponty writes of the lived body. The body is a receptacle of past experiences, of a knowing that bypasses knowledge. Think of a culture as a collective, lived body. The scars of its experiences accumulated over generations and fixed into rituals and mores. A less elegant way of putting this is the language of therapy, culture as a coping mechanism. So why am I referencing this in relation to health equity access? It's time to reset our direction in health research. For too long, Indigenous people have been subjects of research, experimented on without informed consent, and cloaked in terms of a vanishing race, soon to disappear as a footnote in history. We are still here and are building a future for generations yet to come. revitalizing languages and cultures, informing science with traditional knowledge of our ancestral ways, reminding each other of the value of our culture and our ways of being in this world. Our work is urgent, as centuries-old colonial rule has shortened our life expectancy and disconnected us from land and waters of our ancestors. Many Indigenous languages are in danger of extinction with a few fluent language speakers. With their passing, we lose volumes of knowledge of the land, plants, history of places, and our place within this land. Each of us come to this forum with our own lived experiences, and we do not value one over the other. It's about sovereignty. It's about having control over your own life, your health, and your direction. There's richness in diversity and value in openness and inclusion as full partners in developing research. It is my hope that by choosing to serve as patient partner, it will enrich research and open the door to Indigenous-led research on our own terms, embracing our history with deference to our lived experiences and how these experiences have impacted our well-being and health. For equity to work, it must be intentional. A program that's not intentionally equitable has the danger of being unintentionally inequitable. Equity gives priority to those at greatest risk of harm and directs resources to offset the burden in the healthcare system. Equity provides space for those harmed by policy or are disproportionately at greater risk of harm due to forces beyond their control. I'd like to leave you with the words of Norma Rabbitskin of Sturgeon Lake. Reconciliation is not about Indigenous people changing. It's about non-Indigenous people recognizing that Indigenous people have the right to practice our culture as it was given by Creator, and to practice our ways of healing, medicine, and ways of being. I hope more Indigenous people and communities will join efforts to initiate research for the benefit of their communities and for future generations. With that, I'd like to thank you. So I turn it over to Donna. Donna, you're muted.
Thank you. Sorry, I lost audio from my laptop, so I had to switch to my telephone. Thank you very much for the presentation. So now we are going to go into the Q&A, and I just would kindly ask that you submit your questions in the chat if you haven't already. I'm just going to take a look to see if there is anything. I see nothing now, so maybe I'll just kick it off with a couple questions. And so I will start. Dr. King, the two-eyed seeing concept is attractive. However, there are many different Indigenous cultures, even in Saskatchewan. Is it too simple? Indigenous ways of knowing and Western ways of knowing?
Thank you for the question, Tona. So it really is intentionally simple. It was presented by Elder Marshall, who was Mi'kmaq, is Mi'kmaq. I mean, he's still very much with us. And it was intended to illustrate the relationship between Mi'kmaq and the surrounding settlers who came. But we all know that there are many different Indigenous cultures, and certainly in Saskatchewan, we have many different First Nations as well as Métis. And there are also many different non-Indigenous cultures, non-Indigenous ways of knowing. So really both sides of that stereo microscope, if you like, are complex, and we have to recognize that not only are the many different Indigenous contributions, but many different Western ways and contributions. So if anything, if you might like to think of it as an insect eyes, the complex eyes, many different islets that insects have. And so both sides of the stereo microscope are complex, but it does help, I think, when one's thinking about individual contacts, say between a First Nation or a Métis settlement and the researchers who are coming from the university to work together that way. Thank you.
Thank you for that, Dr. King. I see that we have a few hands up. I am going to turn it over to Mateen. You have a question for the panelists?
Yes, I do. Thank you very much. But before I ask the question, let me just quickly ask if the chat function is enabled. I do not see any option on my end to enter chat mode. So I'll leave that with you, Thona. And before I ask my question, I just want to express my gratitude and my emotional reaction to the presentations thus far. And I think many of us are feeling the same way. So I just want to say to all presenters, thank you so much. Now, the question is more specifically for Dr. Asiniwasis, but it could be for all presenters. Now, there is a tremendous dearth of incentivization for outreach work, going where people are and providing them the services that they need. I struggle with that too in my field of anesthesiology and how to incentivize that where services are, let's say, inadequate. We'll just use that word. So should we address this through education, through incentivization of payment schemes, the way doctors are reimbursed, through formation of itinerant bands of healthcare providers who can be deployed at relatively short notice, a combination of all these? What I'm particularly interested in, Dr. Asiniwasis, is your experience. What does it tell you about what is probably the biggest bang for buck here?
So thank you for that question. I think there's a long ways that I could go with discussing this, but I think that, at least from my background being a dermatologist, I trained in Toronto, where it's a very well-serviced area, very short waiting lists, and then I came back to Regina and I just kind of bumbled into getting all these patients from different communities. I connected with Dr. McKinney and started going up, and it was kind of organic that happened and not really pre-planned, if that makes sense, once I kind of saw what was going on. So how, from my personal experiences where I can speak from, and this is truth for me, is that it took me a long time to try to advocate for an extra stipend for these clinics. And I think that, we do have to have some sort of policy or procedure in place to support people who want to do this outreach, because it's a humanistic part of medicine to be able to go and see patients in person. And not just that, like if the virtual care infrastructure is not good, and I've seen that from experience as well, like it's very difficult often to get a hold of patients. The other thing too is if we can deliver the services to the community, like for example, for me, something like bringing along curettes or intralesional Kenalog, or being able to excise cysts or do skin biopsies, those you can't do virtually. So the answer to that is I'm not really familiar what the infrastructure is in Saskatchewan with regards to that, but what I can tell you is that the fee-for-service system, when these patients get very complicated, the fee-for-service system is often not compatible with these complex cases. And my admin will tell you, sometimes it can take over half an hour to even to an hour to try to chase someone down. If their cell phone is off, we have to send them a letter, we have to call the nursing station, the costs do add up. So the answer to that is I'm doing my own thing, is my reality. And if I can't get the region to support me, I'm going to support my own practice through private practice. But like I said, the answer is I don't know, but maybe we should open up that discussion.
Thank you for that, Dr. Asiniwasis. I'm going to move on, and I believe I'm having technical difficulty with the chat, but I did see Catherine Stevenson's hand up. Catherine, if you are still on, please unmute yourself and ask your question. Thank you.
Hi there, it's Kath. And sorry, I was actually just going to mention that there is no chat function on our side. So that might be why you're not getting chat questions. It's just a note, but also take the opportunity to thank all the panelists and keynote speaker for a really thoughtful and thought-provoking time this morning so far.
I see Mamata has a hand up, and Mamata, I'm going to turn it over to you.
Thank you, Tana. And I really thank all the presenters today for presenting such an inspiring and informative session. I'm really very grateful to be having worked with many Indigenous communities and people to work together to see how we can move ahead in a good way. My question is for actually Chief Delrome. I am really truly inspired by what you have said, and I do wish to reach out to you and find out how we can work together. I'm a research scientist at Saskatchewan Health Authority, and I do partner with First Nation communities and people, and I try to work together to find strategies that can help improve healthcare for our people. So I'm reaching out to you and taking this opportunity to see how I might be able to connect and how we might be able to build some partnerships to work together. Thank you. And I would also like to thank Maggie King here. Our paths have crossed a few times, but I'm really looking forward to partner with you and work together too.
Thank you.
Okay.
Tana,
Next question.
I can ask you some of the questions here in the chat. For those of you who are having issues seeing the chat, just so you know, if you did go to full screen, you just have to get out of full screen to see the chat in feed loop. And if you have joined on Zoom only, you will not see the chat function. So I've got a question here from Michelle McCarran. And her question is directed to all the panelists. What are some of the biggest ways that non-Indigenous researchers may help to support Indigenous research and the needs of the individual communities that chose to participate in research?
It's Malcolm, if I could jump in, the best way to get started, at least, is to learn about historical trauma, to learn about Indigenous people and their ways of knowing. And I guess I'll put in a plug for what SCPOR has developed. We have building better research relationships with Indigenous communities. It is a training module. It's available online now, and I would encourage anyone wanting to get involved in research with Indigenous communities to take something like this. I think our module is very good, but there are many others as well. Thanks.
Thank you, Dr. King, for that response. Can I get the next question, please?
I've got a question here from Sandy Kazir. They mentioned embodiment of decolonization is critical in healthcare research. What are some strategies that you recommend for adapting to decolonize research tools and methodologies in healthcare?
Dr. King, Dr. Asiniwasis?
Yes, well, so my last slide, which hopefully will be available after this, talked about 4 aspects of decolonization, and it really references the Truth and Reconciliation Commission to recognize the underlying determinants of the poor health of many Indigenous people, not all Indigenous people, and that's very important to remember as well, and to move forward collaboratively with Indigenous communities, develop relationships, work with the communities to deal with the health issues, not try and do it by yourself or top down, and to recognize Indigenous ways of knowing and doing, bringing in that idea of two-eyed seeing, the best of Indigenous and Western ways of doing. So, and that really is decolonization, because it's a return to this true spirit of the original treaties that Chief Delrome talked about, the canoe and the ship of the Western people traveling in parallel down the river, not interfering with each other. Thanks.
Thank you, Dr. King, for that.
I just wanted to, add, if I may, I just wanted to add that, you know, when you're going into working with communities, not to overburden them with tasks, resource positions for Indigenous people that are working on your team, and also, you know, make sure that they have the equipment that they need to take part fully as partners within the research. You know, give them, if they need the tools, if they need a computer, you know, help them to get access to the internet, find ways to make it compatible for them to take part in a research project, and listen to them. I mean, they have their views, they have their ideals, they know what's best in the community, they know the community best, but not to overburden them and think that they can give you all the answers. That you have to do your part too, to understand where the community's at and what are the things that are affecting them.
Thank you, Maggie. And I'd just like to add to that too. So, I mean, I'm primarily a clinician, but one thing that I have found to take the burden off of these communities is by having a remote care coordinator on site. And again, because my clinical work is kind of going into the research, how that works is we have a centralized separate phone. And what we do for our clinic is we take the admin burden off of the communities, because I just see that they're very strapped with human resources. Like when we're up there, just to give you an example, when I was at Pelican Narrow doing a skin clinic, the nurse practitioner there started running a code. And like, I know you can see that these people are often just overloaded, especially with a pandemic. So what we're trying to do through our center independently is trying to have a remote care coordinator and we have a cell phone, and we provide patients with our cell phone to text. They can text us, they can call us. We have an email, you know, we have a website. So we actually coordinate everything from our end. But one thing that I have learned is that there are burdens to reaching out to these communities, whether it's, you know, the connection is not adequate. One thing we have actually found which works is sending a letter out if we can't reach them. And actually we do have people calling us back. So I think that, yeah, I think that we have to realize that these communities are very resource strapped. And I just wonder if there's any way we could centralize that better through urban centers where there's more services. But then again, like I'm relatively new to all this and I'm just learning as I go, so.
Thank you for all of that. Can I just turn over to see if there are any more questions? We are coming down to the last few minutes, and I'd just like the participants, if there are any more questions, please let me know.
I've got 4 more questions here, so perhaps we'll tackle one more as we run out of time. So I'll select this question from Jason Vanstone, and this is for you, Dr. Asiniwasis. Any thoughts on the role of antibiotic use in further increasing the burden of asthma and eczema?
So again, I don't mean to be a mean person, but one thing that I've learned after being involved in undergrad and postgraduate teaching is that in medical school, residency, and nurse practitioner nursing programs, there's a lot of horizontal and vertical overlap with things like diabetes, hypertension, common things, but there's only a very, very limited teaching on skin disease. And I think that that's starting to show up in more of a crisis of lack of proactive management, and perhaps, like I said, perhaps overprescribing when it's actually a serous flare of atopic dermatitis. I'm not really sure, again, what a lot of these practitioners are thinking, because I'm not there. But what I will tell you, that as someone who did a full residency in dermatology, sometimes I'm like, okay, well, I wonder if this could have been managed differently. I do think that there is a high and concerning level of systemic antibiotics. I think that absolutely can lead to resistance. And I'm worried about there being burdens of things like MRSA, but we can't always get swabs. So it's like, how do we know? So often we have to proactively cover for this if we know that MRSA could be a risk factor. The other thing is the optimization of topical antibiotics. So for example, again, these patients with atopic dermatitis, they have open encrusted skin. If they're scratching, bacteria can get in. They're often colonized with Staph aureus. I find that the role of topical antibiotics can really, really help. I would never dismiss a topical and how that can help from that perspective. Things like fusidic acid or mupirocin actually has pretty good MRSA coverage to prevent that from going to that crusted impetigo or cellulitis. So again, I think it goes back to proactive care. And I think that we need to have skin modules in a culturally sensitive context on how to manage these, because like I said, if we only get a couple of weeks of dermatology in all our years of training, and they're getting these complicated comorbid things like scabies or, eczema on top of each other, and you can't really tell the difference. Like sometimes it's even hard for me to do so. I think, again, we need to have educational modules on managing complex and chronic complex and simple common conditions, so I hope that maybe we can do something with that, because again, this is one of the top conditions we're seeing in children, and the adults, I'm seeing a lot of it as well, but very poorly documented.
Thank you for that. And again, we are at 10:40, and I just want to thank everyone once again, to all our speakers for participating in this important discussion today. And so I would just like to turn it back to Christine, to the virtual stage for some housekeeping remarks, and Miigwech.
Thank you so very much, Tana, for moderating such a very meaningful and powerful keynote panel. I can't thank you enough. And on that note, I really want to echo my thanks to Chief Delrome, to Dr. Asiniwasis, to Dr. King, and to Maggie King. We can't thank you enough for presenting to us this morning. It's been a really powerful experience. So thank you very much. I do want to go over a little bit of what's next on our program. There is a brief 5-minute break followed by the interactive poster session. This is a great opportunity to view the posters if you haven't already, or ask questions, because the poster authors can be contacted through the platform. To visit these posters, please go to the poster hall, and that's on your menu on the left. Right at 11:15, we'll move to our breakout sessions. One is on clinical and health services research, and the other is on community-based research and Indigenous health research. And don't forget, you need to go to the sessions in your menu and select the session you would like to attend. See you all at the poster hall and at the next session. Again, thank you so much.